Hello, good afternoon. My name is Dr. Awais Saeed Abbasi, and I'm a registrar in diabetes and endocrinology, currently working at Good Hope Hospital, Sutton Coldfield, Birmingham, England, which comes under University Hospital, uh, Birmingham Trust. I'm here to present my case report, and I was helped by Dr. Gesh Kalaya in this. The topic of my case report is Graves' thyrotoxicosis leading to right heart failure. My patient was a 37-year-old female who presented with 8-week history of amenorrhea, 6-week history of swelling involving limbs and face, recent onset tiredness. She had heat intolerance and palpitations. She did not have any chest pain, orthopnea, paroxysmal nocturnal dyspnea, or visual disturbances. She did not suffer from any other medical illnesses. She lived with her husband, and she was a non-smoker but a social drinker. She belonged to Southeast Asia and had a language barrier as well. In medication history, she did not take any medications. Clinical examination, initially she had a heart rate of 145 beats per minute with a blood pressure of 110 over 70. Her respiratory rate was 18 per minute. Her temperature was 37.1 degrees Celsius, and her oxygen saturation was 98% at room air. She had mild periorbital puffiness. Her hands were warm. She had raised jugular venous pressure. She had bilateral leg edema and positive shifting dullness. There were no signs of uh, tremor, pretibial myxedema, or no eye signs were noted. On investigations, her ECG showed atrial fibrillation with fast ventricular rate initially, and this was aborted by metoprolol 5 milligrams, which was given intravenously, and later propranolol 40 milligrams orally was started. Her repeat ECG showed S1Q3T3 pattern with T wave inversions in 2,3 AVF and B pulmonale. Rest of the investigations, including COVID PCR, HIV serology, hepatitis B surface antigen, HCV serology, CMV, HAV serology, ANA, and double-stranded DNA, along with ENA, were all negative. Her white cell count, hemoglobin, platelet count, renal function tests, and electrolytes were within normal range. ALT was 69 international units per liter, ALP was 154, and bilirubin was 28 micromoles per liter. Her urine protein creatinine ratio was 41 milligrams per millimole. Her thyroid stimulating hormone was less than 0.01 milliunits per liter with a free T4 of 53.5 picomoles per liter, and free T3 was also raised uh, to 30.7 picomoles per liter. Her TSH receptor antibodies were 52.6 international units per liter. Radiological investigations, including ultrasound, showed moderately diffuse enlargement of isthmus, and both lobes had increased vascularity with slight reduction in echogenicity. Right low lobe had 3.8 centimeter cystic nodule with solid element and increased vascularity, and was designated as intermediate U3 category. There was minor leftward deviation of trachea noted as well. Her CT neg also confirmed ultrasound findings and added that lateral to left carotid sheath there was an unusual lymph node which seemed benign and noted mild right-sided pleural effusion. Uh, these are the CT scan images of the patient, and this is the chest X-ray image of the patient. CT pulmonary angiogram ruled out pulmonary embolus and showed features suggestive of right heart failure, tricuspid valve insufficiency, and right-sided pleural effusion. Uh, Later, echocardiography was also done, which gave the following findings. Her ejection fraction was noted to be 55 to 60%. She had septal flattening and diastole consistent with right ventricular overload, dilatation of right ventricle with impairment of right ventricular radial systolic function was also noted. There was mild mitral regurgitation, moderate to severe functional tricuspid regurgitation was also noted, and this raised a high probability of pulmonary hypertension and biatrial dilatation. And these are the echocardiographic images taken from the patient. As far as management is concerned, the patient was started on loop diuretics, so spironolactone, carbimazole, and propranolol, and there is a plan for right heart and left heart catheterization, and arrangements are being made to shift patient to a specialized pulmonary hypertension facility. Uh, this is from the case. Now, um, a few slides about Graves' thyrotoxicosis and its effect on other organs, especially heart. So, Graves' disease is a syndrome consisting of hyperthyroidism, goiter, orbitopathy, and pretibial myxedema. Hyperthyroidism is the most common feature and is caused by autoantibodies to thyrotropin receptors. Annual incidence of thyrotoxicosis is 0.9 per 100,000 children aged less than 15 years, with Graves' disease accounting for 96% of the cases. And a strong family predominance is noted during adolescence with a ratio of 5:1. Thyroid hormone affects cardiac muscles, peripheral circulation, and sympathetic nervous system in conferring a predictable hemodynamic response in hyperthyroidism. And as far as cardiac manifestations of hyperthyroidism are concerned, uh, they include tachycardia, increased pulmonary artery pressure, increased cardiac output, increased ejection fraction, increased systolic blood pressure, raised myocardial oxygen consumption, worsening of anginal symptoms, increased diastolic relaxation, decreased diastolic blood pressure, and reduced systemic vascular resistance. This is a pictorial presentation of how the thyroid hormone acts on different organs and what it can do to them. This is a tabular presentation of the functions of thyroid hormone. Uh, as we all know, thyroid gland is situated below the hyoid bone and larynx, sitting on top of trachea. It is supplied by superior and inferior thyroid arteries. Thyroid gland is composed of follicle cells surrounding fluid-filled colloid. Uh, about the thyroid physiology, hypothalamus produces thyrotropin-releasing hormone, which stimulates production of thyroid-stimulating hormone from anti-pituitary gland, which acts on thyroid gland and activates production of thyroid hormones, including T3 and T4. And these hormones inhibit production of TSH via a negative feedback mechanism, as shown in this figure. TSH binds to TSH receptors, which is a G protein coupled receptor having alpha and beta subunits. There can be three types of thyrotropin receptor antibodies. Number one, stimulatory, number two, inhibitory, and number three, neutral. In Graves' disease stimulatory thyrotropin releasing receptor antibodies causes increase in thyroid hormone synthesis and secretion. As you can see, this is the model of TSH receptor. There are alpha and beta subunits. And here you can see three types of thyrotropin receptor antibodies. Um, as far as thyroid hormone synthesis is concerned, after the attachment of TSH with TSH receptor, G-coupled proteins cause conversion of GTP to GDP, which causes increase in cyclic AMP, which triggers the synthesis of thyroid hormones. On the follicle cells, there is a sodium iodide symporter, which causes transportation of both sodium and iodide into the cells. Iodide is then transported into the colloid via pendrin in exchange of chloride. Iodide in colloid is oxidized into iodine via peroxidase, and thyroglobulin produced in follicular cells bind with iodine and are converted into monoiodotyrosine and diiodotyrosine (DIT). Bonding of MIT with DIT produces triiodothyronine, and bonding of two DIT molecules produce thyroxine, which is T4. T3 and T4 attach to thyroid binding globulins in the bloodstream and are transported to target cells, where they bind to nuclear thyroid hormone receptor and via causing transcription and translation impart their role on different mechanisms. Here you can see a pictorial presentation of thyroid hormone synthesis. As far as cardiac manifestations of thyrotoxicosis are concerned, the mechanism by which thyroid hormone causes an increase in heart rate is by affecting sympathetic nervous system and decrease in peripheral vascular resistance, which is attributed to increase in nitric oxide production. Increase in cardiac output is caused by increase in blood volume, which occurs due to increase net tubular absorption of sodium. Pulmonary vascular resistance is increased in hyperthyroidism, in contrast to peripheral vascular resistance, which is decreased. Thyroid hormone increase pulmonary vascular resistance by increasing the sympathetic drive, altering energy metabolism, enhancing catecholamine sensitivity, decreasing cholinergic tone, increasing degradation of pulmonary vasodilating substances, and decreasing metabolism of vasoconstrictors. And these are the mechanism by which thyroid hormone affects the cardiovascular system. So in conclusion, this case highlights the importance of considering hyperthyroidism as a differential diagnosis in investigating patients with signs of heart failure since it is treatable and is impediments are reversible. Thank you. And these are the references. Thank you so much for listening.